Question 1. A patient presents to the emergency department with abdominal pain. After evaluation, the physician diagnoses acute appendicitis. The patient is admitted for an appendectomy later that day. What is the correct principal diagnosis for this admission? A. Abdominal pain. B. Acute appendicitis. C. Appendectomy. D. Observation for suspected appendicitis. Answer B. Acute appendicitis. This question tests your understanding of principal diagnosis selection in inpatient coding, specifically for ICD-10. The key here is that the principal diagnosis is the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital. While the patient presented with abdominal pain, the definitive diagnosis of acute appendicitis was confirmed and led to the admission for surgery. Always remember that the principal diagnosis is the condition that prompted the patient's inpatient stay, not merely a symptom or the procedure performed. For example, if someone comes in with chest pain but is diagnosed with a heart attack and admitted for treatment, the heart attack is the principal diagnosis. Here's an easy way to remember. The principal diagnosis is the ultimate reason for the inpatient admission. Question 2. A 65-year-old male receives an annual wellness visit. During the visit, the physician identifies a new finding of elevated blood pressure and decides to manage it. How should this E/M service be coded? A. G0438. B. 99214. C. G0439. D. Both G0439 and 99213. Answer C. G0439. This question focuses on the correct coding for annual wellness visits, AWV, under CPT and HCPCS guidelines. The keyword annual wellness visit is the direct clue. G0439 is the specific HCPCS Level 2 code for an annual wellness visit subsequent, which is applicable for patients beyond their initial AWV. While an E/M code like 99214 or 99213 describes office visits, AWVs have their own unique set of HCPCS codes. A separate E/M code, e.g. 9921X, would only be billed in addition to the AWV if a significant, separately identifiable problem that is not a routine part of the AWV was addressed. In this scenario, managing elevated blood pressure could be part of the AWV or might warrant a separate E/M if significant, but the question asks about the AWV itself. The takeaway here is to recognize that AWVs are distinct from standard office visits and use specific G-codes. Question 3. What does medical necessity primarily mean in the context of medical coding and billing? A. The patient prefers a specific treatment. B. The service or procedure is appropriate and necessary for the diagnosis or treatment of a disease or injury. C. The provider orders the most expensive treatment available. D. The service is performed in the most convenient location for the patient. Answer B. The service or procedure is appropriate and necessary for the diagnosis or treatment of a disease or injury. This question tests a fundamental concept in medical billing and coding: medical necessity. The key phrase medical necessity refers to whether a healthcare service is reasonable and necessary for the diagnosis or treatment of an illness, injury, or to improve the functioning of a malformed body member. Payers, like insurance companies, will only reimburse for services that meet their criteria for medical necessity, meaning the service must align with clinical guidelines and the patient's condition. For example, prescribing an antibiotic for a bacterial infection is medically necessary, but prescribing it for a viral cold is not. Always ensure documentation supports that the service provided directly addresses the patient's condition, as it's crucial for claim reimbursement. Question 4. A patient undergoes an MRI of the brain without contrast, followed by an MRI of the brain with contrast. How should this be reported using CPT codes? A. 70551, 70552. B. 70553. C. 70551, 70553 to 59. D. 70552, 70,553. Answer B. 70,553. This question assesses your knowledge of CPT coding for radiology services, specifically for an MRI of the brain with and without contrast. The concept being tested is combination coding in radiology. When a CPT code exists for a procedure performed both without and then with contrast, like an MRI or CT scan, a single combined code is typically used to represent both phases. Code 70553 specifically covers magnetic resonance (MR) imaging, brain, without contrast material S, followed by with contrast material S and further sequences. This avoids double billing and accurately reflects the complete service. Remember to look for combination codes in your CPT manual when contrast is involved with an imaging study rather than separate codes for without and with when a combined option is available. Question 5. What is the primary function of the CPT manual? A. To list diagnoses and diseases. B. To provide codes for medical procedures and services. C. To define medical necessity criteria. D. To describe durable medical equipment. Answer B. To provide codes for medical procedures and services. This question targets a core understanding of the current procedural terminology, CPT, manual. The keyword CPT manual immediately indicates its purpose is related to procedures and services, not diagnoses or equipment. The CPT manual is a comprehensive listing of descriptive terms and identifying codes for reporting medical services and procedures performed by physicians and other healthcare professionals. These codes are essential for consistent communication between healthcare providers, patients, and payers. For example, a doctor performing an office visit will use a CPT code like 99213, while a surgeon performing an appendectomy will use a surgery CPT code. Always remember that CPT codes describe what was done to the patient, unlike NCCI, which describes why it was done. Question 6. A physician performs a Level 3 established patient office visit, 99213. During the visit, they also remove a skin tag, 11200, from the patient's back. How should these services be reported to ensure proper reimbursement, assuming the skin tag removal is significant and separately identifiable? A. 99213, 11,200. B. 99,213 to 25, 11,200. C. 99213, 11,200 to 59. D. 99,213 to 25, 11,200 to 59. Answer B. 99,213 to 25, 11,200. This question tests the correct application of modifier 25 with evaluation and management E/M services. When a significant, separately identifiable E/M service is performed on the same day as a minor procedure, which often has a global period of 0 or 10 days, modifier 25 must be appended to the E/M code. The significant and separately identifiable aspect is a key clue, indicating that the E/M service was above and beyond the usual pre/post-procedure work. This tells the payer that the E/M was not simply part of the skin tag removal. For instance, if a patient comes in for a rash but the doctor also finds and removes a problematic skin tag, the visit for the rash can be billed with modifier 25. Always apply modifier 25 to the E/M code, not the procedure code, when billing for distinct services on the same day. Question 7. A patient is seen for symptoms of dizziness and nausea. The physician completes a detailed history, detailed exam, and has moderate medical decision-making. What is the appropriate CPT code for this established patient office visit? A. 99,203. B. 99,214. C. 99,204. D. 99,213. Answer B. 99,214. This question assesses your ability to level an evaluation and management E/M service based on the components of history, exam, and medical decision-making (MDM). For established patients, those seen by the provider or a provider in the same specialty within the same group practice within the past 3 years. The CPT guidelines state that either 2 out of 3 key components, history, exam, MDM, or MDM alone, since 2021, must meet or exceed the requirements for a given level. In this case, detailed history, detailed exam, and moderate medical decision-making points to an established patient visit, and moderate MDM specifically correlates to a 99,214. For example, if the MDM was straightforward, it would likely be a 99,212 or 99213, but moderate MDM indicates a higher complexity. Always refer to your ETH/M guidelines for established patients and compare the documented elements to determine the correct level. Question 8. What does the abbreviation HX stand for in a medical chart? I. Hospital. B. History. C. Health. D. Healing. Answer B. History. This question tests your basic knowledge of common medical abbreviations, which is essential for understanding clinical documentation. The abbreviation HX is universally recognized in healthcare as shorthand for history. This includes the patient's medical history, family history, social history, and history of present illness. Understanding these abbreviations is crucial for quickly and accurately interpreting patient records, such as when reviewing a chief complaint or past medical conditions. For example, if a chart states point with HX of HTN, it means the patient has a history of hypertension, high blood pressure. Always familiarize yourself with common medical abbreviations to streamline your coding process. Question 9. Which of the following is an example of a HCPCS Level 2 code? I. 99213, office or other outpatient visit. B. G0439, annual wellness visit. C. J1040, methylprednisolone acetate, injection, 40 milligrams. D. Both B and C. Answer D. Both B and C. This question evaluates your understanding of HCPCS Level 2 codes, distinguishing them from CPT codes. The concept being tested is the specific use cases for HCPCS Level 2, while CPT Level 1 primarily covers physician services and procedures. HCPCS Level 2 codes, often referred to as G, JA, etc., codes, are used for products, supplies, and services not found in the CPT manual. G0439 is a G code for an annual wellness visit, and J1040 is a J code specifically for drugs administered non-orally. Code 99213, an E/M service, is a CPT code, not HCPCS Level 2. Knowing the different code sets helps ensure you select the most appropriate code for accurate reimbursement. Question 10. A patient presents with a painful, inflamed ingrown toenail, left great toe, that requires avulsion, removal of the nail plate. The physician performs the avulsion without anesthesia. Which CPT code should be reported? I. 11,730. B. 11,750. C. 11,760. D. 11,719. Answer I. 11,730. This question tests your ability to select the correct CPT code for nail avulsion. The keywords ingrown toenail, avulsion, and nail plate are crucial clues. Code 11730 specifically describes avulsion of nail plate, partial or complete, simple, single digit. The procedure is the removal of the nail plate. Code 11750 is for a permanent removal with matrixectomy, surgical destruction of the nail root, which is a more extensive procedure. Code 11760 is for repair of nail bed. Code 11719 is for trimming nondystrophic nails. Since the question specifies a simple avulsion, 11730 is the correct choice. When coding nail procedures, always pay close attention to whether the removal is partial or complete, if anesthesia was used, and if any matrixectomy was performed. Question 11. What is the anatomical term for the shoulder blade? I. Clavicle. B. Scapula. C. Humerus. D. Sternum. Answer B. Scapula. This question assesses your basic anatomical knowledge, specifically identifying bones. The shoulder blade is the common name for the scapula, a large, triangular bone located on the posterior side of the thoracic cage. The clavicle is the collarbone, the humerus is the upper arm bone, and the sternum is the breastbone. Knowing these common anatomical terms is fundamental for accurately interpreting operative reports and medical documentation. For example, if a report mentions a scapular fracture, you immediately know which bone is affected. A strong grasp of anatomy helps ensure you understand the location and context of procedures. Question 12. A patient is admitted to the hospital with acute myocardial infarction, heart attack. During the hospitalization, the patient develops pneumonia. How should the pneumonia be coded if it is clearly documented as a complication of the myocardial infarction? I. J18-9, pneumonia, unspecified organism, as principal diagnosis. B. I21-9, acute myocardial infarction, unspecified D, as principal, followed by J18-9, pneumonia. C. J18-9, pneumonia, as principal, followed by I21-9, acute myocardial infarction. D. Only I21-9, acute myocardial infarction? Answer B. I21-9, acute myocardial infarction, unspecified D, as principal, followed by J18-9, pneumonia. This question tests your understanding of ICD-10 CM sequencing guidelines for complications and coexisting conditions in the inpatient setting. The key phrase complication of the myocardial infarction is critical. According to coding guidelines, the principal diagnosis is the condition chiefly responsible for the admission, which in this case is the acute myocardial infarction. The pneumonia, although a serious condition, developed during the stay as a complication, making it a secondary diagnosis. When a complication arises during an inpatient stay, the underlying condition remains the principal diagnosis. For example, if a patient is admitted for surgery and develops a post-op infection, the reason for the surgery is still the principal diagnosis, and the infection is secondary. Always remember to prioritize the condition that led to the initial admission. Question 13. Which modifier is used to indicate that a physician provided only the professional component of a diagnostic test? I-26, B, TC, C-50, D, -59. Answer: I-26. This question focuses on the correct application of CPT modifiers, specifically for diagnostic services. The keyword professional component is the direct clue. Modifier 26 indicates that the physician interpreted the results of a diagnostic test and prepared a report, without performing the technical portion, e.g., operating the equipment, providing supplies. Modifier TC, on the other hand, is used for the technical component. Modifier 50 indicates bilateral procedures, and Modifier 59 indicates a distinct procedural service. For example, a radiologist reads an X-ray performed at a hospital. The hospital bills with the code and Modifier TC, while the radiologist bills with the same code and Modifier 26. Always remember that Modifier 26 is for the interpretation and report, while Modifier TC covers the equipment, supplies, and technical staff. Question 14. What is the primary purpose of the National Correct Coding Initiative, NCCI, edits? I. To identify fraudulent claims. B. To prevent inappropriate payment for services that should not be reported together. C. To set reimbursement rates for Medicare services. D. To standardize medical terminology across specialties. Answer: B. To prevent inappropriate payment for services that should not be reported together. This question addresses a core compliance concept in medical coding. The National Correct Coding Initiative, NCCI, edits. The primary purpose of NCCI edits, developed by the Centers for Medicare and Medicaid Services, CMS, is to promote correct coding methodologies and to control improper coding leading to inappropriate payment. They contain procedure-to-procedure, PTP, edits that identify codes that are ordinarily performed together and should not be billed separately, or codes that are components of a more comprehensive procedure. For example, NCCI might bundle a simple closure code into a more complex excision code. Always consult NCCI edits to ensure that multiple procedures reported on the same date of service are correctly billed and not unbundled. Question 15. A patient has a benign lesion removed from the face, measuring 1.5 cm in diameter. The physician closes the wound with an intermediate repair, measuring 2.5 cm. What CPT code F should be reported? I. 12051, 11442. B. 11442, 12051. C. 11442. D. 12051. Answer B. 11442, 12051. This question tests the correct coding for lesion excision and wound repair, emphasizing the separate reporting of repair when it's more complex than a simple closure. The keywords are benign lesion removed, face, 1.5 cm diameter, which is the lesion size for excision, and intermediate repair, 2.5 cm, the repair size. First, for the excision of a benign lesion on the face, 11442, excision. Other benign lesion including margins, face, ears, eyelids, nose, lips, mucous membrane, 1 to 20 cm, is appropriate. Since the repair is intermediate and has a specific measurement, it should be coded separately using 12051, repair, intermediate, wounds of face, ears, eyelids, nose, lips, mucous membranes, 2.5 cm or less. Always remember that intermediate or complex repairs are reported separately when performed with excisions, while simple repairs are included in the excision code. Question 16. Which part of the small intestine connects to the stomach? I. Ileum. B. Jejunum. C. Duodenum. D. Colon. Answer C. Duodenum. This question tests your knowledge of basic gastrointestinal anatomy. The duodenum is the first and shortest segment of the small intestine, directly connecting to the pylorus of the stomach. The jejunum is the middle section, and the ileum is the final section that empties into the large intestine, colon. Understanding the order and connections of organs is vital for accurately interpreting surgical reports and identifying anatomical locations for procedures. For example, a procedure described as duodenotomy would involve an incision into this specific part of the small intestine. Knowing these anatomical relationships helps you visualize the operative field and select correct codes. Question 17. A patient presents for an initial encounter for a traumatic fracture of the right tibia, open type 2. Which ICD-10 cm 7th character extension should be used? I. A. B. D. C. S. D. P. Answer I. A. This question focuses on the correct application of ICD-10 cm 7th character extensions for injuries, specifically for initial encounter. The keywords initial encounter and traumatic fracture are critical here. The 7th character A is used for initial encounter, which means the patient is receiving active treatment for the injury. D is for subsequent encounter, routine healing, S is for sequela, late effects, and P is for subsequent encounter with malunion. Since the patient is presenting for the first time for active treatment of this fracture, A is the appropriate choice. For example, if the patient returned for follow-up care after the initial treatment, you would use D for that visit. Always remember that the 7th character indicates the phase of treatment for the injury. Question 18. What is the maximum number of CPT modifiers that can be appended to a single CPT code on an electronic claim? I. 1. B. 2. C. 4. D. Unlimited. Answer C. 4. This question tests your knowledge of practical billing guidelines, specifically regarding CPT modifier limits on electronic claims. While there might be situations where more than 4 modifiers are technically applicable to a service, standard electronic claim submission, like the CMS 1500 Forms electronic equivalent, allows for a maximum of 4 modifiers per CPT code. 1 modifier is considered the primary, and up to 3 additional modifiers can be used. For example, if a surgeon performed a bilateral procedure, 50, was an assistant surgeon, 80, and it was a distinct procedural service, 59. You would need to prioritize which modifiers to use or how to communicate the full scenario if all 4 slots are filled. Always aim to use the most impactful modifiers first and consult payer-specific guidelines for complex scenarios. Question 19. A patient is prescribed a new medication for hypertension. What type of medical term is hypertension? I. Eponym. B. Acronym. C. Disease or condition. D. Procedural term. Answer C. Disease or condition. This question tests your understanding of medical terminology categories. The term hypertension refers to abnormally high blood pressure, which is clearly a disease or condition that affects a patient's health. Eponyms are names of diseases or procedures derived from a person, e.g., Alzheimer's disease. Acronyms are abbreviations formed from initial letters. Procedural terms describe medical actions. Recognizing whether a term describes a disease, a procedure, an anatomical part, or something else is fundamental to accurate coding. For instance, knowing hypertension is a disease directs you to an ICD-10 code for diagnoses, not a CPT code for a procedure. Question 20. Which entity develops and maintains the ICD-10 code set? I. American Medical Association, MA. B. Centers for Medicare and Medicaid Services, CMS. C. World Health Organization, WHO. D. National Center for Health Statistics, NCHS. Answer D. National Center for Health Statistics, NCHS. This question identifies the responsible entity for the maintenance of the ICD-10 code set, a key piece of information for coders. While the World Health Organization, WHO, owns the international version, ICD-10, the National Center for Health Statistics, NCHS, a component of the CDC, is responsible for the disease classification system used in the United States, which is ICD-10. The AMA develops CPT, and CMS manages Medicare programs. Understanding which organization maintains each code set helps you know where to find official updates and guidelines for each system. Always remember NCHS for ICD-10, CM, and AMA for CPT. Question 21. A patient presents for a follow-up visit after a fracture of the ankle. The physician assesses the healing of the fracture, provides instructions for physical therapy, and performs a brief exam. What type of CPT code should be reported for this visit? I. An E/M code, e.g., 99213. With modifier -57. B. A CPT casting/fracture care code. C. An E/M code, e.g., 99213, with no modifier. D. No CPT code, as this is part of global surgery. Answer C. An E/M code, e.g., 99213, with no modifier. This question tests your knowledge of the global surgical package, and when E/M services are separately billable after a surgery or fracture care. The concept here is that if the fracture care was handled under a global package, e.g., CPT codes for fracture treatment often include follow-up care, a separate E/M for routine follow-up would not be billed. However, if the fracture care was billed using only reduction codes and subsequent visits are separately billed E/M services for ongoing management, an E/M code without a modifier would be appropriate if it's a routine follow-up without complications. In this scenario, it's implied that this is a routine follow-up and not related to complications or a decision for surgery. A key clue is follow-up visit after a fracture and assesses the healing. Modifier -57 is for decision for surgery. If the follow-up is for a new problem or complication, then a modifier might be needed. The takeaway is to distinguish routine post-operative/post-fracture care, often part of a global package, from separately billable E/M services. Question 22. What does the term bilateral mean in medical terminology? I. Pertaining to one side. B. Pertaining to both sides. C. Pertaining to the front. D. Pertaining to the back. Answer B. Pertaining to both sides. This question tests a fundamental medical terminology prefix. The prefix bi- means to and lateral means side, so bilateral literally means pertaining to both sides. This term is frequently used in medical documentation to describe conditions, procedures, or anatomical structures that affect or occur on both sides of the body. For example, if a patient has bilateral knee pain, it means both knees are affected. Understanding prefixes and suffixes like bi- is crucial for quickly deciphering medical reports and ensuring accurate coding, such as when applying modifier 50 for bilateral procedures. Question 23. A patient received an outpatient chemotherapy infusion for 90 minutes. The drug administered was 5-FU. What CPT code, S, should be used for the administration of the chemotherapy? I. 96413. B. 96413, 96415X2. C. 96409. D. 96416. Answer: I. 96413. This question tests your understanding of chemotherapy administration coding, specifically for intravenous infusions. CPT code 96413 is used for the initial chemotherapy infusion of a single or initial substance, covering the first hour of administration. While a 90-minute infusion technically extends beyond the first hour and would typically involve an additional code for the second hour, 96415, 96413 correctly identifies the initial service. It's crucial to first identify the primary administration code before considering add-on codes for extended time. For example, if a patient receives a 30-minute chemotherapy infusion, 96413 would be the only code reported. Always refer to the CPT guidelines for exact timing rules, remembering that 96413 covers the first 60 minutes. Question 24. Which of the following is a common reason for a claim denial related to medical necessity? I. Missing patient signature. B. Upcoding of services. C. Lack of documentation to support the services rendered. D. Incorrect patient address. Answer: C. Lack of documentation to support the services rendered. This question addresses a frequent cause of claim denials related to medical necessity. The core concept is that for a service to be reimbursed, the patient's medical record must clearly justify why that service was performed and that it was appropriate for their condition. Lack of documentation is a crucial phrase here, as even if a service was medically necessary, without proper charting, payers will deny the claim. Upcoding billing for a higher level of service than performity is a form of fraud, and missing signatures or incorrect addresses are administrative issues, not directly related to medical necessity. For example, if a provider bills for a complex office visit but the notes only describe a simple cold, the claim may be denied for lack of medical necessity. Always ensure that the documentation fully supports every service you code. Question 25. A patient has a chronic condition managed by multiple medications. The physician spends 40 minutes performing an established patient office visit. During this time, the physician reviews complex medical records, counsels the patient on medication adherence, and coordinates care with other specialists. Based on time, what is the appropriate E/M code? I. 99,213. B. 99,214. C. 99,215. D. 99,205. Answer: C. 99,215. This question tests the coding of evaluation and management E/M services based on total time, a critical method especially since the 2021 E/M guideline changes for office/outpatient visits. The keywords 40 minutes, established patient office visit, and the description of complex care management are essential clues. For established patient office visits, CPT guidelines define time ranges for each E/M level. A 99,215 requires 40 to 54 minutes of total time on the date of the encounter. Since the physician spent 40 minutes, this aligns perfectly with the minimum time for a 99,215. For example, a 25-minute visit might be a 99213, but a 40-minute visit focused on complex care elevates it. Always refer to the CPT time ranges for office/outpatient E/M codes to accurately select the correct level. Question 26. Which anatomical term means toward the head or upper part of a structure? A. Caudal. B. Distal. C. Cranial. D. Ventral. Answer C. Cranial. This question tests your knowledge of directional anatomical terms. The term cranial specifically means toward the head or referring to the cranium, skull, which is the upper part of the body. Caudal means toward the tail or lower part, distal means further from the point of attachment, and ventral means toward the front. Understanding these directional terms is crucial for precisely locating anatomical structures and describing relationships between body parts, which is fundamental for accurate documentation and coding. For instance, a cranial nerve indicates a nerve originating from the brain. Always remember these terms as they provide a universal language for describing positions in the body. Question 27. A patient underwent a colonoscopy with removal of 3 polyps by hot biopsy forceps. Which CPT code should be reported? A. 45,378. B. 45,380. C. 45,385. D. 45,384. Answer C. 45,385. This question assesses your ability to correctly code endoscopic procedures, specifically a colonoscopy with polyp removal, using a particular technique. The keywords colonoscopy and removal of 3 polyps by hot biopsy forceps are key. CPT code 45385 specifically describes colonoscopy, flexible, diagnostic, with removal of tumor S, polyp S, or other lesion S by hot biopsy or snare technique. The number of polyps does not typically change the CPT code for this type of removal. The method of removal is what dictates the code choice. Code 45378 is for a diagnostic colonoscopy, and 45380 is for biopsy, while 45384 is for removal by a different method, forceps or snare. Always choose the code that best describes the most extensive or definitive procedure performed during the colonoscopy. Question 28. Which modifier indicates that a procedure was discontinued after the patient was prepared but before the induction of anesthesia? A. -52. B. -53. C. -73. D. -74. Answer C. -73. This question focuses on modifiers related to discontinued procedures in facility coding. Modifier 73 is specifically used in an outpatient hospital or ASC ambulatory surgical center setting to indicate that a surgical procedure was terminated after the patient was prepared for surgery and taken to the operating room, but before the administration of anesthesia. Modifier 53 is similar but used for physician services. Modifiers 52 and 74 are for reduced services or discontinued services after anesthesia, respectively. For example, if a patient is prepped for surgery, but it's called off due to a sudden equipment malfunction before anesthesia is given, Modifier 73 would be appropriate for the facility's claim. Always distinguish between physician and facility modifiers and the point at which the procedure was discontinued. Question 29. According to ICD-10-CM guidelines, what is the correct way to code for a rule-out diagnosis in the outpatient setting? A. Code the condition as if it exists, but add a V code. B. Code the symptoms, signs, or abnormal findings. C. Code the rule-out diagnosis as principal with Z code. D. Do not code anything until a definitive diagnosis is made. Answer B. Code the symptoms, signs, or abnormal findings. This question tests a fundamental ICD-10-CM guideline, specifically for rule-out diagnoses in the outpatient setting. The key here is outpatient setting. According to ICD-10-CM guidelines, for outpatient encounters, a suspected or rule-out diagnosis should not be coded as if it exists. Instead, you should code the patient's symptoms, signs, or other abnormal findings that led to the encounter. For example, if a patient is seen for rule-out appendicitis, you would code the abdominal pain, nausea, etc., rather than coding for appendicitis directly. This ensures that coding accurately reflects the documented conditions and avoids prematurely labeling a patient with a diagnosis that has not been confirmed. Question 30. A patient receives an injection of Lupron Depot 375 mg. How should the Lupron Depot be coded for the drug itself? I. J1950. B. J9217. C. C9203. D. 96,372. Answer B. J9217. This question assesses your knowledge of HCPCS Level 2 J-codes for injectable drugs. The keyword Lupron Depot is the specific drug name you need to locate in the HCPCS Level 2 manual. J-codes are primarily used to report drugs, supplies, and durable medical equipment that are not included in CPT. J9217 is the specific HCPCS code for leuprolide acetate for depot suspension 375 mg. Code J1950 is for leucovorin, C9203 is an unclassified drug code for specific settings, and 96372 is a CPT code for therapeutic injection administration, not the drug itself. Always use your HCPCS Level 2 manual to find the correct J-code for injectable medications.